Welcome everybody to this webinar today, which is entitled Getting It Right, What to Do Now That Patients in England Can Read Their GP Notes. My name is Charlotte Blease and I'm going to be chairing the webinar today. Before we begin, I want to say I feel like a bit of a newscaster. We may have to go to a news flash because it's a very fluid situation in respect of sharing the notes or access to the clinical records in England. But without further ado, I want to get to some housekeeping. Attendees will be muted at all times during the webinar, but during the session, we would invite you to type your questions into the questions section and we'll address them at the end of the presentations. Some answers may be provided during the presentations, so just be mindful of that, and those answers will appear underneath your question. The presentation recording will be available at opennotes.org and at YouTube, at the OpenNotes channel, and you're going to receive an email with links to all of these presentations after the event. A little bit about OpenNotes. OpenNotes is not a product or a software, and OpenNotes, capital O, capital N, is a research unit based at Beth Israel Deaconess Medical Center in Boston. It's a major Harvard Medical School teaching hospital, and at OpenNotes, researchers, patient advocates, a whole bunch of people research the effects of open and transparent communication on patients, care partners, and clinicians. So I want to make a little bit of a clarification here between OpenNotes as the research unit versus OpenNotes, which is a concept, the practice innovation. So for the last 11 years, OpenNotes have worked with collaborators around the country, United States and overseas, to foster and evaluate the spread and implementation of shared clinical notes, a practice which is called OpenNotes. Today, in addition to research, OpenNotes focuses on advocacy and education like this webinar. OpenNotes is funded entirely by federal and philanthropic grants and gifts. Little note on terminology ahead of this particular webinar. So as George Bernard Shaw said, two countries separated by a common language, and there are little differences. So visit notes in the States would more commonly be referred to free text entries in a British context. The visit in an American context would be the patient visiting the doctor. That would be regarded as a home visit in the British context. So it's more common to talk about the appointment or the consultation. And GPs in Britain don't perform surgery in their offices, but the GP surgery is what's more commonly referred to in the American context. It's the location where the primary care doctor works. Ahead of introducing the presenters, I do want to say a little bit about what's going on in England, because today is very much a red letter day. And to back up, NHS England, the policy was that from today, 1st of November, patients accessing their GP care would, by default, have access to their records on a prospective basis, meaning if they had an appointment today, they would be able to get access to their records. But it's a fluid situation, as we said. So the last couple of days, the British Medical Association have voiced sort of strong rebuttal against this policy. We're hearing that potentially it will go ahead, but as I say, we might go to a news flash, or you may be able to fill us in the Q&A about what's happening. But it is likely, nonetheless, that some GPs' practices from today will be opening up the records for patients to read. So our focus today in this webinar is to offer a patient's perspective from England, then to move on and to drill into some research conducted in England among soliciting the views of primary care staff. They're not our views, but they're the views of primary care staff on this innovation. And then we're going to close with Brian McMillan by addressing in a constructive way, when patients do get access, what can clinicians, what can GPs do to basically prepare for writing the notes that patients could potentially read. So I do want to introduce the presenters. Kay Gallacher is a public contributor at the University of Manchester, which is where she's been for the last 8 years contributing. She's currently the co-chair of the Faculty's Social Responsibility Forum and a lead public contributor on a project developing a handbook and app for users of primary care services. She has a marketing and communications background, and she likes to apply those skills to ensure research findings are written in plain English and they're accessible to the general public. We might add to the taxpayers who funded the research. Gail Davidge is a psychologist and a health researcher based at the University of Manchester. Gail has been working as a research associate in conjunction with Brian McMillan on projects concerning patient online access to primary care records in England. And Gail's also leading research exploring how health professionals can be supported to write online consultation notes, the OpenNotes that meet patients' needs. And finally, Brian McMillan is an NIHR Advanced Fellow at the Centre for Primary Care and Health Services Research at the University of Manchester. He's also a practicing GP and a health psychologist. He completed his PhD at the University of Leeds. And Brian is currently conducting research, as I say, into online record access in England and working alongside the NHS Transformation Directorate to improve the experiences of staff and patients who use the service. So without further ado, Kay, please take it away.
Oh, thank you. Thanks, Charlotte. Hello. Thanks for asking me to talk today about my views on access to online patient notes, my notes in particular. But please be aware that what I'm going to say is my own personal views. I'm not pretending to be Mrs. Average patient. And also I fully appreciate that there's lots of issues with this issue for medical personnel. But I'm going to just say what I as a patient actually want from access to my own notes. So I'm going to actually talk about my experiences so far in getting access to my notes, how I think our information should be shared, the nothing about me without me phrase, why I think it's actually valuable for patients in general and me in particular to have access to online notes, what I want to see in the notes, and in particular what I don't want to see in the notes. So first of all, my experiences so far in trying to get access to my notes. So I'm quite fortunate that I live in Salford, where we've been part of one of the first trials in tying GP notes, so primary care notes, and hospital notes together. So I'm aware that my notes have been computerized for several years. In my first role as a public contributor, so talking back 8 years ago, I was on a forum that considered large data health research. And I joined this forum because I was interested in my own health data and who was looking at it, who it's being shared with, where it was kept, that sort of thing. And several people on that forum already had access to their own medical notes. And so I wanted access to mine as well. Knowing that my notes were already computerized, I thought it was really easy. I naively turned up at the surgery reception and asked very politely if I could see my notes. What I meant was, would it be possible to see my notes on the computer at home? Well, you would have thought that I'd actually asked to see their knickers. There was lots of huffing and puffing, and I was told it was going to cost me £50 and it was all very difficult to do. Eventually, after quite a few months, the surgery called and said that it was possible for me to go in and actually look at my notes So I was taken into a room at the surgery with a nurse in attendance. Apparently she had to be there in case I got upset by what was written down. And I was able to look at my notes on the computer. I didn't have to pay £50 because I didn't want them printed out. But there was nothing dramatic in there. There was no mix up with anybody else. There wasn't anything in there that I took offence at. But the upshot to all this was that no, I could not get access to my notes at home. But no explanation why. You know, what? Nobody explained why some people I knew could get access, but I couldn't. So that was probably about 3 or 4 years ago. And then back in February of this year, I heard that everyone was going to be able to have access to their own notes. I called the receptionist at the surgery, and she had no idea what I was talking about at all. Called again in July, absolutely nothing. And now, only because I've been involved with this project, that I learned that it should be today, November the 1st. Yay! Well, maybe. I looked on the surgery website, not a single thing about any access. So I telephoned the receptionist, and she was delighted and said, oh yes, you can have access, you just have to complete the online form. But then of course it wasn't obvious where the form was. I couldn't see it anywhere on the website, and the receptionist had to actually talk me through. And it turned out that the form was sort of 2 or 3 layers into the website. So people who don't know to ask for it are never ever going to be able to find it, and probably won't get access. So next slide. I mentioned the nothing about me without me phrase, and as you can tell from my experiences, all of this trying to get access has all seemed so complicated to me, unnecessarily complicated. I just want to have easy access and ownership of my own notes. And in my experience, this is all about sharing information, parties to my health being equal, nothing about me without me again. I want to be a partner in my own healthcare, and I just want easy access to the online notes and probably clear instructions of how to sign up for access. And of course, everybody's got their doubts about all this working. But one of my own personal fears is that it's going to create yet another divide and create a class of patients who can't see their notes and won't have access to them. You know, maybe they've not got smartphones or computers. So I think something has got to be done to get around this. Why do I, next slide please. Why do I think it's valuable to have access to my online notes? A few points. As I said earlier, it helps patients to be partners in managing their own healthcare, and improves patient safety, so that people can check for example, that they're on the correct medication dosage. I think it will actually reduce demand on the practice. So cut down on the number of telephone calls. So instead of me having to phone to check whether test results have come in, I'd just be able to see online. And things like blood tests, the surgery only contacts you if there's an issue. But I actually want to know that everything's okay, and I want to be able to interpret the results as well. And also, for me, having my own notes, I'd find quite reassuring, so that even if I feel relatively calm, going to the doctors always raises my anxiety levels. And when I get home, I can never really be confident of what's been said or recommended. So just being able to refer to my notes and maybe confirm what I thought I'd heard would be reassuring. And just little tiny things like having online access makes it easier to get other online information. So instead of having to sit in the surgery writing down web addresses, you just be able to make the link online. And a big one for me, because of an experience, is the security of this. I want to make sure that the doctor's written the right things and not mixed me up with somebody else. I heard a horror story about a girl's psychiatric notes who had been, the notes had been mixed up with somebody else's notes, and she was having to employ a solicitor to get the wrong information cleared off her notes. Whereas if she'd been able to see her notes herself in the first place, that mix-up wouldn't have happened. So what do I want to see in my notes? I want language that I can understand, obviously. Something as simple for like a blood test saying all clear or within normal parameters. I want an accurate and straightforward record of my consultation, and a note of the decisions made, medications or treatments that have been prescribed, obviously. This is all quite normal, I think. And dates and descriptions of referrals, and in particular expected result dates, and then obviously the actual results. What I don't want to see in the notes are obviously acronyms, jargon, language I can't understand, technical or medical terms without a lay explanation, and even value judgments. So sometimes you wonder why the person's written, why the doctor's written a value judgment. So finally, what I feel that we as patients need is a positive, proactive response by the medical profession, rather than the passive reaction that I've had from my GP surgery. I must say that my GP is excellent, and this experience of trying to get my notes has really been a one-off. So my plea really is just talk to your patients, communicate with them, and let them know what's happening, if you know what's happening, that is. So thank you, and I'll pass back to Charlotte.
And I'll pass it straight on to Dr. Gail Davidge.
Hi, thank you for that, Kate. It's really useful to hear about your views and experiences as a patient, and I really hope that moving forward things get a bit easier for you in that respect. So now what I'm going to do is just share a more general overview of what's been happening in England. It's been quite an interesting story so far. I've changed the tense of my presentation a few times this week, but hopefully things will all go ahead according to plan. I also need to say that although the plan is for patients to be able to access all aspects of their notes, for today we're going to focus on the free text consultation note, or the open note, as Charlotte explained earlier. Next slide, please. So previously, patients have had to be quite a bit more proactive, as Kay explained, and request online access for themselves directly from their surgery. And even when patients did request access, what they received was quite variable and inconsistent across the country. So patients might have been allowed access to basic transactional functions, so that's things like booking appointments or ordering repeat prescriptions, or alternatively they might have been able to access their summary care record, and that contains basic demographics and some information about allergies and medications. And then a level up from there, patients also might be able to get access to what we call the detailed coded record. And there's a lot more information in there, so that has things like test results, diagnoses, immunisations, things like that, but still no access to the free text consultation entry. And then at some practices, patients have been able to access their full record, including their consultation note, but that has been more of an exception rather than the norm. So as Charlotte explained earlier, back in 2021, last year, there was an announcement by NHS England and NHS Improvement that almost all patients in England would be able to access any new prospective entries within their online record via the NHS app or by another online service. And the rollout date has moved a couple of times, but ultimately the aim is for patients to be able to access everything automatically by default. So if the plan goes ahead today, full prospective access will mean in effect that all patients will be able to see everything in their record from a specified date moving forwards, except tasks between clinicians. And the plan is that's going to happen automatically. So this is a subtle but really important change of emphasis and power dynamic here. So this will mean that GPs will need to be thinking a lot more carefully about what they write in their records, what gets redacted, or even if access needs to be switched off altogether in exceptional cases. So that's a very little bit of background about where we found ourselves today. That doesn't really explain how patients can access their record. So next slide, please. It used to be a bit of a palaver getting access to the record, but now the whole thing is online. You can take a photo of your driving license or your passport, say a few words into your phone, and it's pretty much instant. But we do realise that's not particularly inclusive, and one of the big challenges around this is that many people either don't have photo ID or the digital skills or the resources to do this easily. But if you have got all those things and you can prove your identity and you have your NHS login, then you can view your primary care record online via a really wide range of apps. We've got a couple of examples here. So the most popular one is the NHS app. I think that's got about 30 million users at the last count. There's the AirMid app, there's Patient Access, Evergreen, and all these different apps will give you access to the same bits of information, just in slightly different formats. And again, I think at the last count, there's about up to 30 different apps that patients can use. So it's a very quick whistle-top tour of how you can get access to your record. I just wanted to quickly highlight some of the research that Brian and I have been doing in this area over the last couple of years. So a few years ago, we did some research with patients, asking them what they thought of online record access and how they thought it might be improved. And then what seemed like the next logical step was then to go and ask primary care staff and see what they thought, and maybe see if any of this overlapped with what patients thought was useful. So at the moment, we're working on a project called Impact. And about a year ago, we started speaking to clinical and non-clinical primary care staff to ask for their views. And the sample included staff with a real range of experience, working in different roles, in different locations along the spectrum of more deprived to more affluent areas, to get a feel for what staff thought about this. And although it was unplanned, our interviews actually coincided with the NHS announcement, and some of our participants did talk to us about this in their discussions with us. But for today, we're not going to focus on that because I think that deserves special attention on its own, and that could fill up a whole session by itself. But now that this is almost, but not quite, but maybe by the end of today, become a reality, we thought it might be useful to share some of our early findings from staff, exploring what they think are the main benefits, as well as offering some practical tips on things that they might have raised as a concern. So what do we find out? Well, the main overarching theme that came out of the research was that staff were very supportive of online record access in theory, but often there was a but after they said that. So this was like an overarching theme that went across all of our research. So when applying it to practice, staff had quite mixed feelings, and they identified both challenges and opportunities, which are covered in the remaining three themes of patient-centred care, safety and patient safety, and help with navigating this change. So on the next slide, please. So going back briefly to the first overarching theme, as a general idea, they thought it was great and necessary step forward in acknowledging patients' rights, aligning with legal responsibilities and honouring their existing contractual arrangements. But when it came to how it impacted on practice, there was quite a diverse range of views. So for example, here we have a GP trainee, and she talks about, you know, she's not anti it as a fundamental concept, but she's got real concerns that things might go wrong, and this was quite common. However, we also had staff that were very optimistic about this, and we have a GP here, and she says, you know, she genuinely believes that it's their health, they deal with it 365 days a year, and they should be able to access it. And then we had a small range of healthcare professionals who were just resigned more than anything else, and felt like it was inevitable that this was going to happen, and the best thing they could do would be to be as best prepared as possible for this happening. And then moving on to the second theme, so this was around opportunities and challenges for delivering patient-centred care. So people mentioned things like, for example, patients could have more control over their health information, and that would actually benefit both parties. It would benefit the patient and the clinician, because patients can do a lot more things for themselves, things like applying for health insurance applications, get the information they needed for that. Staff also noted that there was a real opportunity around improving health literacy and helping patients become more active and involved in their health. Also that being able to see what a GP had written would offer some reassurance, and also add as an aid memoir for what had happened in the consultation. And again, around communication and involving others, staff were very keen for proxy access carers. They could see the benefits there, although they could also see some potential practical problems in allowing this. But as a whole, as a theory, they were very keen for people to be involved and to have that access. Everybody had concerns about equity and were worried that online record access potentially might just benefit the worried well. And on the next slide, I've got a couple of examples of some of the things that people were saying about this. So here in yellow, we've got a GP who can see the longer term benefits, and he says, you know, patients can see their results over the last few years, see if it's helping them to get better, and it might spur them on to make some positive changes to their health in the longer term. And then another GP here in green, sort of tealy colour, highlights how seeing it in writing gives the patient some reassurance. They know I've made a plan, it's all written down, they can check back and be like, okay, you said we'd see each other in 8 weeks' time, and they don't feel that they've been forgotten about. And then again, around the equity issue, the fact that it's all done online, it might exacerbate the digital divide, and a lot of our staff are keen to point out that there's certain populations of patients who are going to find it more difficult to access this in an online format. And then under the third theme, keeping ourselves and patients safe. So staff noticed some opportunities and concerns around this. There were a lot of worries that patients might feel more anxious or have their safety put at risk, and this is mirrored in a lot of other existing research out there. Clinicians were concerned about how they might document some of the more sensitive information or safety information around safeguarding, and also thinking around who is going to be accessing this and the possibilities of people that are not intended to read it, reading it. And again, in line with other research, staff were concerned about increased risk of litigation, staff overall well-being and increased workloads, especially at a time in England when there are issues around staff retention and recruitment, for example. Having said that, others thought the increase in workload would be very short term, and the benefits would ultimately outweigh the risks once this practice was had been going on for a longer time. And then on the next slide, please. So we've got a couple of quotes here around some of the things that staff were saying to us. So on the one hand, we've got a GP here in yellow saying, you know, I need to write this stuff. And when he says this stuff, he's talking about sort of safety things, but he doesn't feel safe himself because he knows that patients often give access to different people. But despite this, a lot of staff also felt that that this could actually improve patient safety. And for some of the practices that are well on their way on this journey, they're actively encouraging patients to be partners in this and proactively saying to them, come on, tell us if something's not right, we can have a look at it together and sort it out. And that's been working well for them so far. And then finally, the last theme concerned how these changes have potential to change relationships and the power dynamic. And some people felt that more increased transparency could be a really good thing and help develop and improve relationships and increase trust. And a couple of people were also worried about this and felt that, you know, there's also the potential for people to write something that's taken offence to unintendedly, and that may damage relationships. What else? So they also noted that this really has the potential to completely change the function and the purpose of the record and turn it into more of a shared care record in which patients are now on an equal footing. And also that this shift will absolutely change how people work and how they relate to patients in the future, which highlights a real need for some additional training and support. Can I have the next slide, please? So one obvious change is that health professionals are going to have to think more carefully about what they write in the record and the kind of language that they use. And this is highlighted really well in this quote here with this advanced nurse practitioner who says, you know, some people are really good at it and emotionally intelligent, and some people are pretty crap. You know, you only need to read a section of your colleagues' records to note that we're all very different in how we document things. So that really highlights for us and has spurred us on to do some more research, thinking about how we can support health professionals to be able to sort of meet patients' needs within the note. So now I'm going to hand over to Brian, who's going to talk you through some of the more practical tips that will hopefully help staff to navigate some of the challenges I've just highlighted.
Thank you very much. So, and Kay, thanks very much as well. I think it's really fascinating to hear sort of two slightly contrasting sets of views, almost about, you know, from a patient's point of view and then the clinician's concerns, and how there's hopefully there is a middle ground and we can all sort of agree, and there's a way that we can work together to do this. So yeah, the next few slides are just based on a paper that Charlotte was the lead author on, which has been published, or well, it's in press in the BMJ. Hopefully it'll be out soon. That's the paper there, and it's just some suggestions aimed mostly at clinicians about things we might want to bear in mind, given that patients are increasingly going to have access to the records. Whether that happens today, I think it is going to happen increasingly in the future, and I suspect it probably will happen in the very near future. Just as a disclaimer, both Gail and I are funded by the NIHR, but our views don't represent the NIHR. They're the sort of views of myself and Gail, just to get that clear. So next slide, please. So there's a few things I thought it's just worth mentioning in advance, things that I'm not going to cover. So there's loads of research on the OpenNotes page, and there's loads of systematic reviews looking at the evidence for, you know, the benefits and some of the drawbacks of patient records access. So I wasn't going to cover those today. If you want to read about those, you know, there's a link on my slides, which hopefully we'll get to share at the end. Again, I'm not going to talk about the evidence for the impact on workload, and the evidence is a bit mixed, but again, I've shared a link there for some relevant studies looking at the impact on workload, and the same goes for the risk of litigation as well. Because it's still a little bit unclear, I'm not going to go into what the legal situation is in England at the minute. I think that will become clearer as the day goes on. And also, I wasn't going to cover whether or not this could have been done differently. So Dr. Amir Hanan was on a radio program on Radio 4 quite recently, talking more about an opt-in model. Not exactly opt-in, but just this idea that patients need to be sort of taken through the potential downsides of things like, you know, what would you do if you saw data in your record that wasn't yours? What would you do if you saw something in your record that upset you? Or what would you do if someone was coercing you into sharing your record with them? And that's a slightly different model, and I think it's an interesting debate, but obviously don't have time to go into it today. Then there's been a lot of discussion about obviously if doctors are concerned about, say for example, there's a concern about potential child abuse, that might not want to be shared immediately until the doctor has been able to clarify exactly what is going on, but they would still need to document it somehow. So there are ways that can be redacted from the record, and I've shared some links for any of the British listeners who want to have a look at that in more detail. I'm sure you probably are already aware of this information anyway. And again, you know, there's lots of information on there about how to disable records access altogether for patients who you're concerned might not have the capacity to fully understand the implications of accessing their record. And the last thing I'm not going to talk about is proxy access, and there's a link there to the RCGP guidance on giving carers or parents access to somebody else's record. So it's quite a long list. So next slide. What I did think would be useful, it's in mostly the British clinicians on the call, if there are any. I recognise most of you are probably in your surgeries right now, but might be listening to this later on. Just some tips based on our research and based on that paper that Charlotte's got in the BMJ. The 6 tips I thought would be to inform patients, involve them, explain what's happening, put yourself in their shoes, reduce your use of jargon, and provide support. I realise I do run the risk a little bit of teaching my granny to suck eggs here, but I just thought it might be useful just to throw some of those tips out there. So next slide, please. So as Kay mentioned, quite a lot of patients aren't aware that this is even happening at the minute, and I think if it is happening and people are their records on the NHS app, then it's good to raise awareness about this in advance and make people aware that this information is going to appear on your phone if you've got the NHS app or a similar app, and that can be done through various routes, you know, posters, texts. Consultations are a good opportunity to raise this. So say you've sort of formulated quite a difficult plan with a patient, and they're sort of looking like they might not be able to remember everything you've suggested, so like a decreasing dose of steroid regime or something along those lines. That's an opportunity to say you can go home and log in, and this is all written down if you want to have another look when you get home. And you know, again, the next point on is that is one of the benefits, that it can be used as an aid memoir. Or people often ask me, when am I going to get my results? So now we're going to be able to say to people, you know, you can log in next week and your results should be on your record. Once we've looked at them, and providing there's nothing to worry about on there that we want to talk to you about, your results will be there. If there is anything we want to talk to you about, we'll be in touch anyway. And then I think there's also an opportunity, you know, if you're in a consultation with the patient and they're saying there's a risk, or that, you know, they're saying that they're in an abusive relationship, or you're worried that, you know, there's bruises that you can't explain, it might be an opportunity to say, do you want me to hide this in the online record so that it's not visible, or do you want me to turn your online access off for a while until we can sort this out? Next slide. Involving patients in what you write, I think it's a good idea. So if the patient's in the room with you, you can say what you're typing out loud. You can spin the screen round, providing there's no safeguarding concerns, and show them what you're typing, ask them if they want to add anything. If you're doing a referral, you could dictate that referral while they're in the room, and again, just check they agree with what you've said. If you're filling in a referral form, you could take them through that step by step and check they agree that you're ticking all the right boxes. Next slide. Just explaining the differential diagnosis. I think that there may be a bit of a temptation to leave things out. So I think, so say for example, I think a patient's got irritable bowel syndrome or IBS. At the back of my mind, I'm always going to be wondering, especially sort of a woman, could this be ovarian cancer? Because some of the symptoms are quite similar. And certainly in the past, I would always have put that as one of my differential diagnoses. I think it's important to still do that. But to say to patients, you know, if you see this in your record, I think the most likely explanation is you've got IBS, for example. It's right down on my list of differential diagnoses. There's a very, very slight chance this could be cancer. I'm putting that in the record because we don't want to miss it if that's what it is. And that goes with blood test results as well. I think it's a good idea to tell patients what blood test you're doing and why. And again, that CA125 would be for ovarian cancer, which is a standard test that we do for someone who's presenting with what we think is IBS, but we can't diagnose IBS until we rule all the other more serious things out. So I think it's a good idea to tell people that in advance. And then if there are any shocks further down the line, at least they've been prepared for it. And at least they don't go home and Google CA125 and think, oh my God, my GP thinks I've got cancer. He told me he thought it was IBS. Why is he testing for this? And then, you know, it's also an opportunity if we are using medical terms such as BMI or body mass index, that could be an opportunity just to say, you know, BMI, that's your weight accounting for your height. I'm just going to put that in we're aiming for somewhere between 18.5 and 25. Yours is 27. You know, it's just so you could view it as an opportunity just to tell people a bit more about how you're thinking. Next slide. And then I think it's a good rule of thumb to think, you know, if you were reading your record, would you want to read this about yourself? So, you know, while we might say obese in the record, we're saying that word in a factual medical way, that someone is technically obese if their BMI is over 30. It doesn't mean we're judging them, but patients might think that. So you could rephrase it and just put BMI over 30, especially if you've already explained what BMI means. And instead of saying per historian, you could just say they're unsure about what happens when you ask them, or refuses to, prefers not to, known drug abuser, reports using. You know, it's simple. It doesn't detract from the information that's in the record. It's still factually correct, but it just comes across maybe as a little bit less judgmental. Next slide. And again, so I think this is going to be one of the trickiest things for GPs in the UK, because we've only got 10 minutes. It's very difficult to get out of the habit of using abbreviations and acronyms, and they save us a lot of time. So SOBOE saves us typing in short of breath on exertion, and that, you know, those minutes are pretty valuable when you've only got 10 of them. But EMIS has got some quite good tools that convert abbreviations into full text, and you could get just 4 letters would convert into as many sentences as you want. So you could get SSRI converted into the whole description of how you've started an antidepressant, how you've explained what the likely side effects are, how you've explained that it might take 5 or 6 weeks before it's going to start to work, what they should do if they find themselves in a crisis. So that could be sort of like a mini essay, all just from 4 letters that you type in using EMIS. System 1's got some similar tools. They're not, in my opinion, they're not quite as good as the ones in EMIS, but there are tools in System 1 you can do similar things with. And there's also third-party tools that will enable you to convert acronyms into full text as well. You could do it manually, that'll take a bit more time, or as I mentioned previously, you could just explain what the abbreviations in the record mean. The NHS app's got a dictionary built in where people can look up terms that they don't understand. But I think some of the system tools, especially the ones in EMIS, are probably the way forward. Next slide. And then finally, I think it's important to remember that not everyone's going to want to access their record online. Some people might still want access to some of the information that's in there, but just not in a digital format. So there are some good examples of practices in England that have used digital champions that get people together to run a little session on how to get online and how to access your record and the benefits of doing that. So, you know, I think that's an example of good practice. There are desktop options of most of the online records access services, and that means you can do things like increase the font size or change the background color or get the information read aloud to you. So that gets over some of the problems with health inequities and sort of problems with access. And there's some good tips on AbilityNet for things that people can do to make apps a bit more accessible. But I think we probably should also remember that some people just won't want a digital option, and for those people, those are the kinds of people who we should still be printing out information leaflets for, rather than just assuming that they're going to read the text that we send to their phone. You know, just check, is it okay if I send this to your phone, or would you rather print it out? Most people say just send it to my phone now, in my experience. So those are my quick tips, and I apologise if any of those seemed a bit sort of blatantly obvious, but maybe you've picked up a few little ideas there that you might not otherwise have thought of. And yeah, that's it from me. Thanks.
Okay, thank you, Kay, Gail and Brian. Those were really good presentations. We're now ready to go to the Q&A, and Deb Wackenheim is moderating the Q&A. So can you tell us what we're seeing in the question box? And please fill in the question box too if you want to throw out another question in the next 14 minutes.
Great. So there was a question for Kay where you talked about forms you had to fill out to get access, and this person was interested in understanding what the forms were and what kind of information you needed to provide.
Well, once I got into the form through the surgery website, it was completely simple. So it just needed my name, address, date of birth, and so that I think that was it. I'm just going to look at the website and tell you name, address, date of birth, phone number and email address. And that was it. That was all that they were asking for. And then, as Gail said, I had to attach a photograph of my passport or my driving license. So that all went through really quickly. And then I got an email, which I've still not completed because I don't understand it, saying register for these online services. Please choose one of these online service providers. No explanation of what an online service provider actually is. And there's things like Pharmacy to You Limited, Redwood Technologies. There must be about 20 different service providers on this list. No idea what they are at all. So as I say, I've not got round to actually choosing one yet, because I'll have to get in touch with the surgery again and have an explanation for it, unless somebody here knows what it might be.
Well, we could answer that question if you want us to, or we could answer it later on. I mean, it's basically just that so in England they've opted for like a market model of how people can access their records, so rather than just a nationally provided service, which is what the NHS app is, there's a choice of around 30 different apps or online sort of logins that you can use, and they all do slightly different things. They all give you the same information, but they present that information in a slightly different way, and some of them will give you extra information, so extra sort of health information. So yeah, that's what they meant by online services. It's just that there is about 30 different providers that you can use. The one that most people know is the NHS app, but there are a lot of other providers out there as well.
The NHS app isn't actually on there. That's the one I would have chosen, but it's not on the list.
Interesting.
Yeah. So it's because they're sort of commercial providers that I was querying, really. So anyway, it's probably part of a longer discussion or a different discussion. But so yes, access to it was very easy, but getting to the form itself was harder than I would have expected it to be.
Gail, you're muted. It looks like you're sharing something.
Rookie error there, sorry. I just wanted to add that some practices have taken that a step further and involved like a consent process where they take patients through the reality of what it's going to be like looking at the record and check that they're okay with seeing certain bits of information, or asking if they want bits in there or other bits on there as well.
Okay, so the next question I think will actually go to Dr. Del Banco, who you now see on camera, who's one of the OpenNotes co-founders. Others can certainly add to it as well. Primary care health professionals are not used to patients accessing their GP records. Should this not constitute a key interactive module to be added to medical school's curricula? And then someone added a follow-up comment. I'll just read that quickly related to that question. I agree it's key to train medical students. Patients Know Best, which is the first personal health record integrated with the NHS app, offers its platform free of charge to healthcare education institutions to train the next generation of healthcare professionals. It's used, for example, by the medical school at the University of Manchester. So Tom, did you want to talk a little bit about what you're doing in this area?
I just wanted to comment first that I thought this was a wonderful discussion. Work has been going on in England and in Sweden long before we began in America, and it's fun to have everyone as colleagues. I thought very quickly bringing a bit of our experience into focus would be helpful. And the Nothing About Me Without Me, actually, first time I heard that, Kay, was from a Norwegian nurse at a seminar in Salzburg in 1998, and I looked it up, and it turns out to be an old Polish aphorism from 3 centuries ago, but it certainly has legs, and it has meant a lot to me. The other metaphor that means a lot to me as a doctor, as a primary care doctor like Brian, is that this is kind of a new medicine, and that medicines are designed for the greatest good for the greatest number. Go back to your Jeremy Bentham and John Stuart Mill, the great English philosophers. And utilitarian purpose, the goal of a medicine is to help most people, But what we know about medicines is there's no medicine yet invented that doesn't hurt some people or isn't contraindicated in some people. And the hard thing about OpenNotes really is sorting out that for each individual and getting it right. But what happened in America was Jan Walker and I got a grant. And the grant, we were told, you just flick the switch. Don't do any education. Don't do anything fancy with the patients or the clinicians. Just see what happens. And we did that with 10,000 patients and 100 primary care doctors. And what we basically learned is that patients loved it. And doctors who were very nervous about it found out it wasn't so bad after all. And we've been doing studies ever since. We've written probably 100 papers, mainly about ambulatory care. The most scary paper that we did was when we asked doctors and nurse practitioners who'd been doing it for at least a year, what did they think of it? And we were thrilled to learn that from these experienced clinicians, that 75% of them were very much in favor of it. 65% of them said they'd recommend it to colleagues, but there was still a goodly number that didn't love it. And I don't want to pretend otherwise. And there are doctors who would have liked to have my head, and there are other doctors who smile at me in the hall and say, nice work. So it's a complicated medicine. We're now 15 years into it. To our astonishment, a year ago, it became national law. Patients now have access, free and readily electronic access to any computerized notes. And we will learn the fallout from that as time comes. That's our experience. It's been a very positive one. I think patients will say that. The last thing I wanted to allude to is Ms. Gallacher's point about class. The biggest fear I had is that this would be what's called a yuppie intervention. Fancy people with various machines would be able to get access, and the underserved people with the digital divide, et cetera, would not be able to benefit from what I thought was a positive thing, open and transparent communication. What we learned is that when such people do get access, they get greater benefits than anyone else. So we're pursuing a lot of our activities now and trying to widen access to people so that they have a better chance of seeing what we think about them or what we write about them. Anyway, thank you for inviting me to make comments, and terrific seminar. I learned a lot.
So did you want to touch on quickly about medical schools? That was the question that I posed with.
We actually got a grant for 174 precious Harvard medical students who are just starting out. And for 2 years now, we're going to be working with them on a curriculum about OpenNotes. We're working with them and their faculty because we're terrified that they will learn a lot and then go up on the wards or into the offices and the faculty will say, stop this nonsense, we don't like it. So we're working with both the doctors who are teaching them and those who are doing it. And we're very excited by the first results. I can tell you that the anecdote is that the patients and the students are very enthusiastic, have had a lot of ideas that we never thought of. And I'm hoping actually now to turn them into researchers who study this along with us, because they'll be much better at it than we will be.
It might be also worth adding, because I think that American experience, we're seeing a lot of universality in different countries, with disparate healthcare systems, with this pushback. So similar to Kay, patients really like the idea, doctors are incredibly anxious about it. And I think if Maria Hegland was on the call today, on the webinar today, she would talk about the pilot study at the University of Uppsala, where I think she was reported, her team were reported to no less than 9 different authorities. So it was like scenes from a Nordic noir, just the anxiety associated with it. But in fact, it's now part of life. The sky didn't fall in. And again, not to say that there are not those residual issues that need to be resolved, but I think there's comfort in knowing that this has happened before.
Good.
There's a couple of questions of whether there will now be access to mental health notes, or once the sharing starts.
So,
Brian,
I mean, for England, or I mean, in England, it may work a bit differently, but there is obviously quite a lot of the patients I see will be suffering from things like depression and anxiety, and those notes I won't be treating those notes any differently than I would for any other presentation. There's another service in England called IAPT, which is Improving Access to Psychological Therapies. And they are mainly CBT counsellors who work within a practice. And my understanding is that if you're a practitioner working in a GP practice using their system, that your entries would be visible to patients whenever the default access option goes live. Then there's a lot of secondary and community care psychological services. They will use different systems, or they may use the same system, but it won't be in the control of the general practice. And if that's the case, the NHS England programme, those entries won't become visible by default. Patients would need to apply for access to those separately. That's certainly my understanding.
Okay, thank you.
We have time for a quick question. Now we're 2 minutes to go.
I don't know if this is quick, but I'll pose it because it's important. Basically asking about, it's a long question, so I'm shortening it, the burden of the workload of clinicians based on the experience in the US and or Scandinavia. Can you tell us about whether the fears of some clinicians about the increased workload are justified?
Probably Tom can answer this, Amber. I know that in our BMJ paper that NHS Digital, and correct me if I'm wrong about this, Brian, because I know things are changing all the time, but they stated that early adoption sites in England said that switching to this prospective access did not increase workload. I don't think they've changed that. That's already in England, but
yeah, I think there was about 16 GP practices that turned it on early, and NHS England did some work with them. This is just repeating what's on their website. According to those practices, they didn't notice an appreciable increase in workload. Some of them reported a decrease in the number of requests for certain things. So yeah, I mean that was sort of early preliminary data. It would be interesting to see some bigger studies and maybe more objective measures. It's a difficult thing to measure, I think.
Tom should speak to that too, yeah.
The general experience in our country is that it's, quote, a non-event. In fact, the most common question I got from my colleagues when we started is, are you sure the computer's working? We don't hear much from the patients. And some will cite saves work, as Ms. Gallacher implied, that the patient can do homework and bring it to them, and as Brian implied, and that can actually make work less for the doctors. Some say it makes more work, and what we don't know what it means is whether as they adapt their notes and learn to write somewhat differently, whether that takes more time or whether it really makes more work. So there are no clear answers to it, but we've certainly not had loud complaints from doctors, boy, have you made more trouble. Now, the trouble with OpenNotes is it's also tangled up with the electronic health record, which doctors love to hate. And so it's very hard for them to disaggregate the notion of kind of open and transparent communication with their patients, with their wrestling with the electronic health records as they evolve. It's very hard to separate that out.
So I want to close the webinar. I want to thank all the speakers, and Tom Delbanco, Amanda, Deb Wackenheim for organising all of this as well. The webinar is being recorded and will be available on YouTube, as I said earlier, in the coming week. Everyone who registered will receive an email with a link to the recording, and please take a look at OpenNotes.org for free resources and information. And thanks to everybody for joining us.